Okay, so it's being recorded. So just a little bit of housekeeping for those who are joining in probably for the first time for the Insigneo research seminars. Just to let you know that we are doing it hybrid now, and welcome to everybody. Not just those who are joining for the first time, but welcome to everybody. So we are organizing this in a hybrid fashion. Those who are Insigneo members and Insigneo associate members, this means that you can come into the physical space, which is in the Alfred Denny conference room. As well today, and we have also coffee and cakes. So starting from today, so keep an eye out for the remaining Insigneo seminars this semester and the next one. Great, awesome. So without further ado, I'm very happy to announce that today we have with us Dr. Nazarian. He is associate professor of orthopedic surgery at Harvard Medical School. He's also the director of Musculoskeletal Translational Innovation Initiative at the Beth Israel Deaconess Medical Center. He has biomedical engineering degrees from the University of Boston and also from ET at Zurich. The title of his presentation today is Relaxin-2 for the treatment of arthrofibrosis. So Ara, whenever you're ready, please go ahead and
perfect.
Welcome.
Thank you very much. Thank you for hosting me. By way of disclosures, I'm a co-founder of a company called Orthopaedic, a biotherapeutics company that basically is looking to commercialize a technology that's related to this research. And I'm a named inventor on filed patent applications and patents detailing some of the work. By way of our funding sources, we have received funding from the NIH through different mechanisms, the DoD and the HMS Blavatnik Therapeutic Challenge that pertains to the presented work. Arthrofibrosis is basically a highly relevant debilitating disease. It occurs in many, many joints in the body, and roughly about 50 million American adults suffer from arthrofibrosis, roughly about 4% of the US population, with the highest prevalence being in the shoulder. So while it's prevalent across the entire body, glenohumeral joint is the main area of this type of joint fibrosis. The arthrofibrosis results from joint inflammation, so it could be resultant from trauma, could be resultant from surgery, from infection, or idiopathic, which frozen shoulder basically is qualified under. So when you see patients that undergo physical therapy after ACL repair or something, part of the reason is that basically you go through the process of motion, and they put your leg in these machines that make this motion. So the whole point is that the joint doesn't get stiff. So post-trauma and post-surgical joint stiffness are very, very real and a major issue that orthopedic surgeons face on a daily basis. So having some kind of a solution to this that addresses this fibrotic tissue buildup over time is sorely needed. In terms of the looking at the problem is that there's a dysregulated wound healing response that is driven by aberrant TGF-beta1 signaling. So for instance, for joint stiffness, you go from these multiple stages. In stage 1, you start having your range of motion is pretty okay, but you start having some synovitis, which is resulting from the secretion of pro-inflammatory cytokines, and so that as you move to a stage 2, you start to have reduced range of motion. You start seeing some capsular thickening, which basically are resulting from fibroblast recruitments, and then move to stage 3, which again really reduces range of motion, and at the start to the capsular thickening really settles in, and then moving on to stage 4, which is basically a further reduction in range of motion, and where myofibroblasts and ECM sort of pervade the synovium. So at this point, your capsule has thickened, and the whole joint space is filled with fibrotic tissue. It's extremely painful. You cannot move your arm. So this is the process that happens, that you basically can't take care of yourself. You can't brush your hair. You can't brush your teeth. You can't function. And so frozen shoulder, which is one of the prevalent mode of this disease, occurs in patients, and basically the time frame goes from a few months to about 3 or 4 years. So during this period, you actually end up having significant loss of range of motion, significant pain, and inability to do things, and it affects quality of life quite often. It's seen more often than not in middle-aged people, and for every 8 men, there's 10 women that are afflicted with it. So it's just a slightly higher affliction in a female population and much higher in the diabetic population. So the currently available treatment options have limited efficacy. You use corticosteroid injections, they use physical therapy, they use NSAIDs, manipulation under anesthesia, or capsular release as like the sort of the surgical interventions that are the last resort. And the problem with those is, if you basically do anything surgically, all you're doing is, you're basically triggering additional scar tissue formation, which then further compounds the problem. So there is no real problem that, there's no real solution that addresses this at the fundamental level. So you basically address the symptoms and try to make make it less painful. And but in general, there's no treatment available for it. Some of the clinical candidates that are available now, they fail sort of to address the underlying causes of fibrosis. So Xiaflex is a medication that is bacterially derived collagenase that is on phase 2 trial. And so the problem is it's a collagenase, so basically it it gets rid of collagen indiscriminately in the joint, and that's something you really don't want to do. And the other one is Zilretta, which is a sustained release corticosteroid that is on phase 2 trial as well. It's directly injected into the joint, but again, it only addresses the the effects and not the actual problem itself. So these are things that are important, to consider. So Xiaflex is an immunogenic, is non-specific, and Zilretta is basically a pain management treatment. So there's no treatment that addresses the underlying disease. So this solution is what's really intriguing about this work is that this is a sort of a clinically inspired solution, and it started from bedside, came to the lab, and we're hoping that we'll be able to move it back into the bedside. So Dr. Rodriguez, who's our chief of orthopedics at our hospital and a longtime friend and collaborator of mine, he noticed that early on, a few years ago, when he was treating patients, he had a few female patients that had distal humeral fractures. So distal humeral fractures are pretty terrible. In the sense that you can easily you can put them back together, the bone heals, everything is fine, but these patients basically end up having permanent loss of range of motion. And funny enough, my grandpa actually had that. I remember when I was a kid, and my grandpa had a distal humerus fracture, and sort of it clicked in my head much later, obviously, in my life. And his right hand, he was always, he never had full range of motion. His right hand was always sort of in this position, and he couldn't really straighten out his right hand. So it's one of those terrible fractures that you don't gain your range of motion, unfortunately. And what he noticed that in a span of a year or so, he ended up having to operate on 3 or 4 young patients, young ladies who had distal humeral fractures. So he fixed them up, and they went on their way. And then they come back a couple of years later, and to his astonishment, he saw that these patients had regained full range of motion. So and it was like, well, how would that be possible? Because this normally does not happen at all in this population. So after some, prodding around, we noticed that all these patients had become pregnant and had delivered full-term pregnancies and had delivered babies after their fracture repair and with their second visit. So we started thinking, what could be possible? That was the only thing that was common among these 3 patients, or 4. I can't remember the exact number at this point. And then so we realized that this might have to do something with pregnancy. And then further exploration of this, led us to the antifibrotic peptide Relaxin-2, which is basically a peptide that is released in the body during pregnancy, that basically to loosens the ligaments and allow for the birth canal to widen, so that childbirth, you can have natural childbirth. So we're like, wow, so this potentially there's an effect for relaxin that will do this. So we started to think about this, and started to talk to some of our other collaborators, namely Dr. Grindstaff from Boston University, about how to formulate a solution that could leverage this information. So what's relaxin? Relaxin is basically an effective antifibrotic, antifibrogenic peptide that could be used for treatment of arthrofibrosis. It is endogenously occurring in peptide hormone. Its hemodynamic, cardioprotective, reproductive, and antifibrotic effects are its key hallmarks. It's a small peptide, and basically it works based on a coupling of increased matrix metalloproteinases, downregulation of tissue inhibitors of MMPs, increasing cyclic AMP levels, and the decrease of myofibroblast differentiation, which basically results in reduction of excess collagen, which in the form of extracellular matrix remodeling. Relaxin signals through the Relaxin Family Peptide Receptor 1, RXFP1, and sort of RXFP1 activation results in a nitric oxide upregulation, which increases MMP expression to reduce fibrosis, and it inhibits PSMAD2, which is a mediator that's involved in profibrotic effects of the TGF-beta1. So it has a sort of a coupled effect, that both reduces fibrosis and also reduces basically the fibrotic effects of profibrotic effects of TGF-beta1. And it has an extensive clinical history and strong safety profile. And what has happened in this process is that it's been used for cervical ripening, it's been used for scleroderma, and for acute heart failure, which has been the last case that was tried by Novartis. And all these trials basically failed at the phase 2, at the phase 3. And the reason being that they really didn't consider the pharmacokinetic limitations of these drugs, and they had non-relevant endpoints in these clinical models. So in the case of the acute heart failure, relaxin has a very, very short half-life, and sort of they basically injected them into intravenously into these patient population, and they had an excellent safety profile based on the data from the FDA. However, they failed to have efficacy because it just washes off through your system pretty quickly, so it just never gained enough sort of a level to be able to have a therapeutic effect. And so we thought that in order for us to make this happen, we have to think about using relaxin in a non-systemic manner and go and use it as a local level of a therapeutic for arthrofibrosis. So what we did was we came up with the idea of developing an atraumatic model of arthrofibrosis that we could assess longitudinally. So we looked at some of the options. We thought we could do a trauma model that you could go in and you can sort of scratch the articular cartilage level, and which will generate fibrotic tissue. And but the issue was that it was a pretty heterogeneous model, and you end up with having a lot of noise in your model built on that. So based on that, we decided to come up with a immobilization-based model that basically we would go in and we tie the humerus to the rib cage and to the scapula for about an 8-week period. And what we will do is basically we immunize the shoulder, and during this period you end up having loss of range of motion, and they end up having a stiff joint, and it gets filled with fibrotic tissue. And then after then after the 8 weeks, we can remobilize, we can remove the sutures, and then the limb is free to move, but now the animal has joint stiffness. And the other issue that was important to consider was we had to look at an outcome measure that would make sense from a clinical setting. When the patients go see a doctor, nobody does a biopsy on a patient to look at the histology of the tissue for this. They look at the range of motion. So for us, it was very, very important to have an outcome measure that clinically makes sense and translates in a way that you would do a clinical trial if you were to try this in patients. So we then came up with the idea of measuring a system that will allow us to internally control for torque associated with maximum internal and external rotation in these animals prior to fixation, and then determine the recovery afterwards. So what we would do is we would measure the range of motion of the animals before we conducted the surgery. So we would know what is the full range of motion of the arm. Then we do the surgery and then wait for 8 weeks, remove the sutures, and then you measure the range of motion again. And at that point, you can see that there's a significant reduction in the range of motion from the baseline. So you have a very good idea how this works. And in terms of our measurements, we have inertial sensors, and we had displacement measurement that allowed us to measure the sort of the range of motion and also know where the range of motion stops, because of the inertial sensors allows you to say that when you're reaching resistance in the ends of the range of motion, so you can automatically detect where the range is. And obviously, as we stated, this is a clinically relevant readout that we could also be used as an endpoint in a clinical trial. So what we noticed was that, this atraumatic induction of contracture increases joint stiffness and histologically represents arthrofibrosis. So here you can see, like, if you graph of a sort of torque versus angle, you can see that the healthy, sort of the blue background is sort of the contracture, and then the dotted line is the healthy baseline. So there's a significant drop in the contracture of the joint compared to the baseline. And on the histologic slides, you see there's a fibronectin staining of the coronal cross-section of the both healthy and contracted glenohumeral joints in the rats. And you can see capsular thickness, which is a hallmark of arthrofibrosis occurring in these two groups. Which basically mimics what you see in humans. So relaxin has antifibrotic and antifibrogenic activity against human fibroblasts-like synoviocytes in vitro. So for this work, we did a dose-dependent antifibrotic response in primary cell lines derived from human synovial cell. And you can say that, here that basically suppression of alpha SMA and myofibroblast phenotypes with relaxin treatment. So you can see the negative control, and then you have the TGF beta 1 here that you see the green lighting up, and then with relaxin that you start goes back to the negative control level, and this in this experiment, and you can see the relative collagen 1 expression that basically depending on the dosage. So then what we went on this, after we did some of these initial studies and developed the animal model and was able to measure range of motion, when we went in a very basic study of just trying to inject relaxin into the joint and see if there's a change. So here, what we see is that at the 100-degree line, you see that you see a straight line. So that 100-degree is basically your the baseline range of motion. So the animals, you would see at baseline, they were around 40 to 50 degrees. Initially was their reduced range of motion. The 100-degree is basically their healthy baseline range of motion. So you can see at day 0, these animals they're all pretty constricted. And then as we move forward, so for instance, the red is the control. You see that, there's motion, but the range of motion does not really reach much higher towards the baseline. And then the purple one is a single intraarticular injection. So you see, you get a little boost on day 1, but again, the effect wears off and it kind of tapers to the same thing. And then the blue line, you will see a multiple IV injection. So again, we injected the same dose multiple times, systemically into the animals, and it really didn't make an effect in terms of restoring the range of motion. However, on the green one, that you see that, basically this is 5 injections that happen over a 10-day period. So we injected these animals at day 0, day 2, day 4, day 6, and day 8. And within this 10-day period, when the animals got 5 doses of the relaxin injection, we saw that the range of motion increased, and then it just stayed at the 8, sort of up to the 8 weeks of follow-on period, which is roughly about 2.5 years in human life, if you sort of convert rats to humans in terms of life. So we were able to restore the range of motion with 5 injections over a 10-day period, and have the range of motion stay in that range. For the other treatments, for both the for the single dose injection, it was this one dose of one of the injections that we did for the systemically, and for the multiple IV dose, it was the same exact dose as the green dots. So the values were comparable to one another in terms of the injection of the material. And if you look at the H&E and fibronectin staining, you will see that at the top you have the healthy tissue. You have a very nice sort of joint space area. You have a clear delineation, and then you come in the middle, and this is the no treatment contracture group, and you see that basically the joint space is completely obliterated, and you have fibrous tissue forming all around that area, and you have lost that the clearly defined joint space. And then after the treatment, this is the histology that you see again. You have a nice joint space back in there, and much more similar to what you saw in a healthy non-treated group. the same thing again you observe with the capsular thickening, basically in the middle slide to the right with the fibronectin staining, and then how the capsular thickening is pretty similar between the treated and the control groups in the population in these animals. So the issue that now we face is that the clinical translation of relaxin faces a pharmacokinetic barrier. So our previous clinical programs utilized systemic administration to overcome rapid clearance, obviously, and so that was an issue. So multiple intraarticular injections may also lead to decreased clinical compliance, because if you have to bring in a patient 5 times over a 10-day period to inject them for this, that's not something that's reasonably accomplished, and you end up not having any kind of an effect, because you're going to have a loss due to compliance. So what we thought would be important is to have a continuous infusion of the relaxin inside the synovial capsule. So basically, that allow us to have a sustained release formulation to tailor the drug delivery solution to the problem. So this was the approach that we thought would be a worthwhile endeavor to go forward with based on the results that we had gained. So we showed that microparticle released biologically active over a 6-week period with biologically active relaxin in these microparticles. And if you look at this graph here, you will see that basically you have a linear range that goes up all the way here, to around day 30 something, and then it eventually tapers off. So basically we have a 6-week window that we are able to deliver the depot of the relaxin into the joint effectively. And so basically, and this is showing basically the red line shows you like at the day 10, and then you have a day 25. So you can see that pretty similar profiles in terms of the release versus the RLX activity. And if in here basically is a representation of the microparticles, PLGA microparticles that we use, that these microparticles degrade via bulk erosion and sort of maintain the integrity throughout the linear release region. So initially you start at day 0, you have the particles, and then you start seeing some erosion basically at the surface levels, and eventually go all the way until they've basically been depleted of the depot inside them and crumbled up. So now going back to the same issue, here what we see is a similar graph, except this time if you notice the range of motion is, again, the baseline is at 100 degrees, but we were able to go all the way down to 20 degrees much more consistently than the previous data set during that 8-week period of immobilization. And so what we had noticed on our first study was that we were using regular sutures to tie the arms to the rib cage, and some of these sutures were had come off prematurely during that 8-week period. So these so the immobilization wasn't perfect, and because of that, these animals did have some wiggle room, basically literally in their arms, and were able to move their arms slightly. So the reduction in the range of motion wasn't as dramatic and wasn't as consistent. And once we noticed that this was happening, then we modified our approach. And for this study, we actually used sutures that had sort of with those fiber wires we used, which are much stronger. And we saw that none of them actually broke during the 8-week period of immobilization that we had, and we were able to very reproducibly accomplish an 80-degree reduction in range of motion on these animals. And here again, you see that we did the injection. So the blue full circle is single relaxin injection with the sustained release formulation with the microparticles. Again, you see you go all the way down to 20 degrees, and then you work your way up and come up to the baseline. The solid orange that you see is basically, again, multiple injections. So we repeated the same study that we went all the way down, and we injected them 5 times over a 10-day period. And again, they come back up very similarly to the single sustained release formulation and restore range of motion. And then the other two hollow circle and diamond basically show injections without the treatment over time, but basically with vehicle. And so it's either microparticle or with saline in case of the 5 injection group, and obviously similar approaches and not range of motion. And on the contralateral side, you see that on the other figure shows the healthy joint when there was no contraction, and the range of motion on each animal. We also measured the range of motion on the contralateral side, and we showed that it was basically at which is hovering around the 100-degree baseline as an internal control for all the groups. So this also shows the same thing now, except this is for the range of motion in terms of the external range of motion, which is the majority of the changes that we saw, because of the 60, you know, of the 100 degrees, 60 degree of the motion is from the at the external rotation, and 40 degrees for the internal rotation. So again, we saw very consistent results in the healthy joint, and then again the same component noticing in terms of the range of motion. Then here we're showing a histological profile of the H&E stain of the single injection of the Relaxin Microparticles, which restores the healthy joint architecture and again, not seeing any damage to the articular cartilage, which is a significant concern in this place. So on the left side, you see at the 2 weeks, and at the 8 weeks, you see a healthy shoulder, nice, you know, nice joint space, everything looks good. And then you have the multiple injection of saline. Again, you see a very sort of occluded joint space with leg tissue. And then now you have multiple injections of relaxin, and then you have single injection of relaxin with microparticles. And again, at both 2 weeks and at 8 weeks, you see a very nicely, clearly delineated joint space, and a very clean sort of edges of the articular cartilage on both of these concerns. And then you see the safranin O inset that, you know, showing the same thing, you know, nice staining on all these groups. So what was interesting to observe was that, you know, this the relaxin actually mitigates some of the foreign body response that is associated with PLGA microparticle administration. So here, if you look at this, you know, the orange ones is basically these are, you know, the saline, multiple injections of saline or multiple injections of relaxin. So there's no microparticle here. So there's very little inflammatory activity happening at either day 14 or day 56. And then the blue is basically, so the solid one is relaxin with microparticle, and the hollow one, the hollow blue, is just a PLGA microparticle itself. So at both of these, you see that especially in the day 56, there's a significant level in reduction of the inflammatory infiltration that occurs in this in the microparticle plus relaxin group compared to the microparticle group. And we show that this effect is basically local, because the graph on the right is the left contralateral shoulder of these animals, and we're showing that there is no effect there. So whatever's happening, it's all local, and it stays within the shoulder that was injected, and the other joint did not show any kind of an effect to that in terms of any kind of a inflammatory response. And so this was an encouraging component for us to be able to see that, you know, that the relaxin actually had some effect in terms of mitigating some of the inflammatory responses resultant from the vehicle itself. And then we did some additional work to look into the microparticles, that, you know, the way that they release themselves in the animals. So the orange lines, you will see this is basically an injection of relaxin into the animals, and this was a sort of a small PK study that we did, that we would sack the animals after, you know, 15 minutes, 30 minutes, an hour, 2 hours, 4 hours, 3 hours, and then 6, and all in all. So over many time points. And then on the blue ones, you see basically the release profile of the relaxin over time with the sustained release formulation. And obviously there's a big difference between these two. And this data here shows the glenohumeral joints and the periarticular soft tissue in terms of the release profile of the relaxin and the microparticle sustained release relaxin. And one of the other things that we noticed was if the relaxin microparticles sort of minimize the systemic drug exposure while maintaining locally elevated concentrations. So if you look at the black dotted line, that's basically your baseline level of relaxin that's shown in premenopausal women. And then if you see the orange ones, basically we have kidney and plasma, where when you have this relaxin injection, you know, you have these spikes after the 5 injection, goes up, comes down, goes up, comes down, sort of this process. And then the blue lines are showing basically the presence in both kidney and plasma of the relaxin from a sustained release formulation that sort of, it's up higher during initial uptake, and it sort of tapers down, and it gets pretty close to what it is in terms of premenopausal women's level observed relaxin in their body. So it's a much gentler sort of presence compared to the multiple injection dose type. And now we wanted to see how this will work. So we were fortunate that we used the rat, and rats do have RXFP1 receptors, and also rat relaxin is almost identical to human relaxin. For these studies, we actually used human relaxin in these rat models, and because the structures are so similar, everything worked pretty well in terms of our studies, and we were able to generate these results. And also that the rats do have RXFP1 receptor. So we were thinking about this, about using a larger animal, and we thought of using a rabbit, and it turns out that rabbits don't have RXFP1 receptors in their joints. So that was sort of a no-go for us in terms of making an animal model, and they realized that actually dogs do have them, and so large animals are going to be conducted with beagles because it's a model that has been used previously, and there is RXFP1 receptors in the joints of dogs. So what I present to you here is this is actually RXFP1 staining in human tissue. So this is both at the capsule and at the cartilage level. So what you see is at the top left, you see that there's abundance of RXFP1 receptor on the capsule, which is very helpful, which means our treatment is actually able to the relaxin is able to bind to the receptor and be active and reverse the fibrosis, as we've observed in all the previous studies with both range of motion and histology. Whereas if you look at the cartilage, articular cartilage, we don't see any staining of RXFP1 receptors in the cartilage, which is a huge news that that we're not because of the lack of the receptor, we're not causing damage on the articular cartilage, which is a significant concern. So this study done in actual human tissue that was from discarded tissue from post joint replacement studies that showed this finding that sort of puts to ease a major concern for us that you don't want to be reversing the fibrosis in the joint, but also damage the articular cartilage and cause other problems down the road. So that was the main concern, and the lack of receptors at the articular cartilage level really sort of made this much more clear for us. So in conclusion, we have developed and validated an atraumatic model of shoulder arthrofibrosis that allows us to have live longitudinal assessment of frozen shoulder and evaluation of response to treatment in this. We've demonstrated a proof of concept, sort of a proof of efficacy for Relaxin-2 as a treatment option for arthrofibrosis using multiple intraarticular injections. We've also synthesized and characterized a bioresorbable sustained release delivery system for Relaxin-2, which we've been able to show that it restores joint range of motion and architecture, and also cleans up the joint space from fibrotic tissue with one injection, which makes it a much more sort of a compliant and better way to treat patients with one treatment, as opposed to having them come in on multiple times in a short span of time. And we've overcome some of the pharmacokinetic barriers with sustained release concentration of relaxin and low systemic exposure, which basically majority of the sustained release occurs into joint and doesn't bleed out too much into systemically. So clinical translation is transferred to a biotherapeutic startup co-founded by the co-founders of the study, and in collaboration with the institutions that we worked. So in terms of the translation, and which is a big area of focus for our group, given that most of our projects are translational in nature, it's basically we're going through this pathway of talking about how we can take some idea from a lab, do the work that we need to do, and how this sort of translates into a startup setting, or into potentially becoming a product that could be used by used for the patient. So you have, from a manufacturing perspective, the goal is to be able to figure out the scale up and the process freeze, and then conduct preclinical studies. So that will sort of get us to a point of been ready for an FDA Interact meeting, which is a meeting that you meet with the FDA. It's like the pre-IND meeting. And so they give you some feedback, and you do some pharmacological proof of concept with And our option is to follow this as with an orphan disease status, given that these joint contractures are a major problem for kids with Duchenne's muscular dystrophy, with kids with CP, and with other SMAs. And so these kids really have a problem with a lot of joint contracture, and to a point that obviously they're not mobile, they cannot take care of themselves. But because of these severity of these contractures, what happens is a lot of times, even caregivers cannot, sort of manipulate their arms and legs to be able to clean them or take care of them. So this is it's a terrible problem. And in case of DMD, so now there's a couple of therapeutic options that are available now that basically extends their life and addresses the underlying problem of the disease, but it does not do anything about the contracture. So they happen to live longer, but they just are as miserable as they were before, because there's no change in their quality of life. So we think there's a significant opportunity to be able to use this therapeutic in these kids and allow them to have some dignity and get some of their range of motion and some of their abilities to function back. And so that's the pathway that we're focusing on right now with kids with CP. And part of the reason that being is that, with these kids they come in regularly to the hospital to get injections for Botox. So this makes it from a perspective of, this is all the things that you learned about how you worry about how your science can be translated. This is something that, we had no idea before. So, obviously we had set up our model as part of a frozen shoulder model, but the problem is you have to figure out how to translate the technology in a way that it will work in a clinical setting, and in a way that it will work from a regulatory perspective, and it will be a clear enough process that institutional funding will back you up, so that when you're going through the venture round to raise funds to do the work, they have to see. So it's very important. What is your indication that you're going after? What is the mechanisms that this indication gets reimbursed? Who gets reimbursed? And these are all the things that you have to learn, that, in order for anything that you do to translate, you have to consider all of these things and sort of and act accordingly, because otherwise it doesn't matter how great an idea you have. If this path isn't clear, nobody's going to put money on it. And if nobody's going to put money on it, it's not going to go anywhere. So this is the unfortunate reality that you never hear or learn about as an engineer or as a physician. And then this reality sort of sets in when you start going down this path. We're fortunate enough that we learned a lot of this sort of on the job, after butting heads and, failing and knocking on different doors. So we finally figured things out. And we have a startup. There's a team of people that know and do this, have done this before. So we're moving along in this process to get to the Interact meeting. And then from there, the goal is to have the engineering run of the material, which means it's one level below a GMP production. So GMP is good manufacturing practice. So this is the kind of production that you need to have to be able to put this drug in a patient. So the engineering run is you get everything done. Basically, it's not quite GMP, but it has all the same processes. And you go through to make sure that you can do everything that you're supposed to do for the GMP run. And then you can use those for some of the PK and PD and other sort of dose finding studies that you will do in a large animal. So that run, basically, it allows us from a manufacturing perspective to figure out how to make the relaxin and how to scale it, how to make the microparticle and how to scale them and put the relaxin into the microparticle. And then also allows you to do all this PK, PD and dose finding and all these things that you have to do in a large animal model, which sort of gives you further confidence that you've passed the stage of efficacy in rodents and you moved on to a large animal. It's relatively similar size to humans and a different a higher order, because rodents are awfully resilient and they bounce back from just about anything, and so this is a very important part that we will do. And from that we will be then we will have all the stuff that we need to be able to be ready for a pre-IND meeting. An IND is investigational new drug, and that's where you go in and sort of you get your manufacturing figured out, you get all your GLP, PK, PD, toxicology, all these things that need to be done in a large animal setting. You get all of those done, and then you prepare, and obviously that, when I say you prepare, you get somebody that does this for a living. They prepare this for you, and then you go for an IND submission in front of the FDA, in prep for phase 1 trials. So we're about 18 months away from getting to that IND submission point, and that's what we're working on at the startup level to be able to move this to that level and start in the first in human trials. And yeah, that's pretty much it. I just wanted to give you guys a little talk about how we do the science part, all the stuff that we've had to go through and learn, and also how sort of this translates into from out of the lab and into a setting that you can actually one day see this in patients, hopefully sooner than later. That's it, and thank you very much. And I would like to acknowledge all of our funding sources that without them we wouldn't be able to do any of this work. Thank you.
Great, thank you so much. It was a fantastic talk. This is such a cool story, really. From finding a molecule that could restore the problem, and then through careful animal studies and developing a delivery solution, really impressive. Thank you also for giving a nice overview of the regulatory process, which I know the FDA is quite a juggernaut, and it's of course of great interest to many of us also at Insigneo. One of the things you mentioned when you're speaking about the regulatory process was about a large animal model. And I think the first question from Professor Damien Lacroix is about that, something about that, but also there are other aspects also he wants to, he has a question about. So what I'll do is I will make Damien presenter and let him ask the question. Damien, you can switch on your microphone now.
Yeah, okay, great. Thank you very much, Art. It was a great presentation. I really enjoyed that. Yeah, I was wondering, it was kind of a generic question really, but I was wondering if you had any ideas why arthrofibrosis is more prevalent in the shoulder, and whether the fact that, this is the most, the joint that gives the most free range of motion is related to that, and whether, and for me then it's also, begs the questions on, how can you actually choose the right model when you actually do in vivo, and whether you actually need to try to have a joint that is similar to the shoulder in this sense, that it has a high range of motion.
You're absolutely right. I do think that the significant range of motion has a lot to do with this. I mean, it's incredible how much your arms move compared to any other joint in your body. And what we have done, and I didn't show this in the presentation, but we have stained all the other major joints, the hip, the knee, the shoulder in the human body, and the ankle, and they all have RXF3 receptors like we have seen on the capsule. Okay. So that part is prevalent. So if you have receptors, you're gonna be able to deliver the depot and bind to the receptors. So I think that's an excellent point. And yeah, the question about the animal model and what joint you go, that's very important, because we work this from a perspective of orthopedic surgery. So what is the problem? Arthrofibrosis. Where do you see the most of these patients come? So the funny part is, Dr. Rodriguez is a trauma surgeon, so he sees this every day in a trauma setting and in a surgical setting. So they all end up with a stiff joint. The problem that we decided to use arthrofibrosis was trauma is a different beast, in a sense that if you want to base a trauma-based model, you're going to have a lot of variability in your model at the baseline, and that's going to really confound your study. So that was the main reason that we chose not to go down that route. And then we said, then why don't we look at an immobilization model, because it's a much cleaner model, and it's a very simple procedure. You do this, it's very reproducible, and we learn how to do it better, by using better sutures, as we went through this process, and it worked really well. And the funny part was now that we had to take this and now do some additional work with animals with DMD, for instance. We have rats with DMD that we're working on them to basically show that this process is duplicated in a setting of fibrotic, a neuromotor disease setting. Mm-hmm. So yeah, so let's say if we had the crystal ball, we would have done that from the get-go. We would have done this model. And the models that exist are not perfect. The animal models that exist for neuromotor disease such as DMD are not perfect. So what we could do is we would basically have a DMD animal, so you have the phenotype, but you also do the surgery on these animals, and then so you can induce further joint contracture, and then we would have worked on that one. So now everything will be perfectly lined up. But we didn't think of that because we're like, there's 10 million people that have frozen shoulder. It's a real problem.
Yeah.
And you want to address that, but that's not how venture fund because they're looking into how is that treatment get reimbursed, what is the path for treatment for them, and if it's clear, and if it is there's who's getting paid and how much, then they know, okay, I think this is a good horse to bet on. But if it's not clear, then they will not fund it. So this is the kind of things that you learn that you never learn in any setting, So yeah, that was an interesting education for us.
Great, thank you for sharing this.
Yeah, and also the other thing you learn is that if you make something that you tell them that this is going to be cheaper, that's a bad idea too. You would think it would be a good idea, but it's not.
Good. Thank you.
Yeah.
Thank you, Ara. Next question is from Enrico. Enrico, I think you can already switch on your mic.
Yes, thank you, Ara. Very nice talk, very useful.
Good to see you.
Good to see you. I have a question more about the measurement of the disease itself, and then characterization of the effect of the treatment. So, of course, you base everything in your model on what you could measure clinically. So the range of motion is your primary outcome that you want to measure and you want to assess your treatment upon. But I was just wondering whether there is any plan of doing some detailed in vivo imaging on the tissue or of the joint to see whether you can better identify when the problem starts and how the model is reproducible in defining the stiffening of the joint, and if you can have even better improve than the doses and the timing of the intervention.
So again, the way that because this is a project that started, with Dr. Rodriguez and I. He's a clinician, and I'm an engineer scientist. So we looked at this from a clinical perspective. So when these patients come to the clinic, it's very clear. Right. So it's very clear they have a range of motion. They have a problem, joint stiffness. They don't do an MRI study on these guys in a clinical setting. It's all based on, the surgeon looks at it. They literally do a range of motion measurement, and that's why we were like, and what we had seen from the initial reviews that we did of previous FDA failures of people that had used relaxin is that they had some ridiculous outcome measures that they had chosen for their studies that had nothing to do with what you want to see. And I have to, it's been a while ago, so I'm gonna write them down to remember them, because I was like, I might not know a lot about, how to run a clinical trial, but why the hell did you choose this outcome measure? And why did you think on something that has a half-life of a 30-minute and it's a good idea to give them systemically and expect things to happen? So we were shocked. So we were like, let's not make these mistakes. So that's why we chose the range of motion, because that's the only thing that physicians do. You don't get at least in the United States, they don't get an MRI. Yeah. So and from a practical purpose, I think you're right. I think it would be nice to do imaging on these guys. The issue is that, where we do in our building, where we have animal facility, we do not have a preclinical MRI set up. So we have to move them to a different building, and it becomes a nightmare of quarantine and this and that.
Of course, logistically it's very difficult. Yeah.
Logistically, then it becomes a much bigger problem. Yeah. But you're right. It would be very nice. Part of the reason also that we didn't do MRI imaging is that you do histology, and histology is God's truth at the end of the day. When you really see the tissue, when you're like, really, you can stain them at different stains and you see exactly what's happening. And quite honestly, if it works, if we're able to do MRI, like some kind of an MRI imaging that we can see these fibers, I think that would be great. And part of that is also what we're working on with our other shoulder work, which is looking at partial rotator cuff tears, which is, and that's a major problem. And when do these partial rotator cuff tears, there's asymptomatic, when do they become symptomatic? When do they start, progressing from a partial tear to a full tear? So there's a whole host here that, all we do right now when we do an MR, all we do is we see fatty tissue infiltration. You know, there's no studies, there's no MRI that you do on patients that you could see the fibers, that you could see changes in the fiber orientation, or any of these things that would clue you in that, oh shit, something is happening here, we have to worry about this maybe, and so this patient needs to change their activity so they don't progress into a full tear. So we don't have that. So that's sort of an area that we're actively looking into for partial tears, but we have not in this scenario.
Great, thank you, Ara.
Thank you, Ara. I have one question, just curiosity. You walked us through the whole process of how you found relaxin, and then you did the animal experiments. Could you walk us a little back, and how did you narrow down on relaxin? Because you said that also there are some other animals, I think if I understood correctly, who don't have this mechanism. If you could explain a little bit the background to that.
So this is where it gets into dangerous territory, and an engineer and an orthopod try to figure out what happens in endocrine, so and so when these patients came by, we were like, he takes care of these patients on a daily basis. He's been doing it for 20 years, and he's like, I've never seen a patient get range of motion back, when you have this humerus fracture. So, and we kept looking at these, and I'm like, how come this could happen? So we're like, oh, they're all women, okay. But then we went into the charts and we looked, and it's like they all got pregnant. They all gave birth. So we were like, okay, this is a common clue that in all these 3-4 patients, they all got pregnant. And then we started thinking back, so what does happen in pregnancy? And then this is like, you get relaxin. You get a massive dump of relaxin into it systemically, and that's why, pregnant women, if you've been around pregnant women, that they have a very loosey-goosey, basically gait pattern. So they have loose joints. They're a little bit unstable in all of these parts, and it's because of relaxin. So that's how we sort of connected the dot to relaxin. It wasn't some magical thing. It was us, kind of fumbling our way into it. So yeah.
Amazing. Great. Thank you so much. Let me look quickly. Well, it seems like there's no further questions for you. So that's great. So I would like to thank again, Ara. Thank you for coming for this fantastic talk. It was really, really exciting. And I'm sure everybody who came by also enjoyed a lot. So yeah, maybe we'll see you again sometime physically. Oh.
Perfect. Thank you so much, guys. Appreciate the invitation. Thank you.
Thank you.
Have a good week.
Bye. You too.